Thank you very much, Gary. Welcome all, evening all. This is the first in a packed programme for 2023 of Redline Group webinars. I watched a couple of the previous webinars on the YouTube channel, and I talk far too much, so I'm going to talk really briefly, a few essentials, and then hand over to the main event for the night, Valerio Celentano. But first of all, just very briefly, as I mentioned, it's the first of our 2023 program. Delighted to have so many people registered, which is terrific. We're going to record the session and we're going to post it on the Redline Group website and also on the YouTube. And we were going to try and stream it to the J-Pouch Support UK specific Facebook group, which is affiliated with ourselves. I don't know if that's going to be possible, but just from the point of view of privacy, if you don't want to be identified at any point, then you might want to blank your camera. Everyone's muted anyway, so that's fine. So that's the first thing. Second thing, I've got 60 people registered, which is really fabulous, and that's really great. The details of the other webinars are on the Redline Group website, so please enjoy this evening and then join in and register for the other webinars if you're so inclined. I think Gary wanted me to mention we've got 100,000 hits today on the Redline Group website, which is fabulous. That's the new website that we just had in place for a couple of years.
I just that's not 100,000 today. That's 100,000 in total.
In total, yeah. That's good clarification, Gary. Thank you. One can dream. Yeah. So that's really fantastic, and I think it reflects the terrific content on the website. A lot of that is down to Gary. So thank you for your efforts there, Gary. What else? There's going to be an opportunity to have questions, present questions at the end of the presentation by Mr. Celentano, and I'll go through the ways of doing that when we've heard the webinar. But just to say, you can post if you wiggle your pointer. For those who are new to Zoom, if you wiggle your pointer over the screen, at the bottom of the screen, up comes a number of icon buttons. If you click on chat, up comes the opportunity for you to post a question. So if you type your message where it says type message in there, type in your question on an ongoing basis throughout the presentation, then we'll be able to pick that up. We probably won't be able to ask all the questions on your behalf at the end, but that's a way of asking a question so you don't forget it. All right. Anything else? I think that's done, isn't it, Gal?
I think so,
yeah. Okay, right. With no further ado, I'm going to hand over to Mr. Valerio Celentano, a consultant gastrointestinal surgeon, colorectal surgeon of international note, a gentleman who began his medical training in Naples in Italy, which I assume is where you're from, and has had a number of professional roles and training roles in France, in the UK, and also in America. Has a specific interest, amongst other things, in inflammatory bowel disease, and in particular the surgical treatment of inflammatory bowel disease with the ileoanal pouch surgery. So from our point of view, he's an outstanding person to have as our first speaker for 2023. Ladies and gentlemen, I give you Valerio Celentano.
Thank you very much. I mean, it's a real pleasure to be here with you this evening, talking about pouch surgery. And I must say thank you again for all the work you do in supporting patients and prospective patients during the journey for pouch surgery, and sharing all the information that patients very often can get from the healthcare profession. As you said, I work in London at Chelsea Westminster hospitals, where I've established the IBD and Ileoanal pouch surgery center. And the focus of today's talk will be J-pouch surgery, how we make the pouch surgery operation, what are the different steps or stages of the surgery, and what we need to do before, during, and after the surgery in order to treat some of the possible problems that can happen. And we will also talk about when is a good idea to do more surgery in order to try and fix some of the problems that can happen with, in particular, with revision when we do pouch surgery. What is an ileoanal pouch? So the ileoanal pouch is one of the options that patients can have after a colectomy, which is the operation to remove the entire large bowel, which is the colon and rectum has been done. And it's a way to restore what is the normal continuity of the gastrointestinal tract by joining the small bowel to the anus. The two main reasons why we do these operations are ulcerative colitis, which is a chronic form of inflammatory bowel disease, and also FAP, or familial adenomatous polyposis, which is a genetic condition. And most of the details that I'll share with you today are related to ulcerative colitis, but they can be overlapped with FAP as well. And we will have a very close look at how surgeons use the small bowel in order to create a replacement for the rectum, which is the J pouch. Before we go into the pouch surgery itself, I just wanted to have a bit of an introduction of some of the wording that you might hear pretty frequently around pouch surgery and this evening's talk. So the top picture here showing the large bowel, which is made of the colon and the rectum, which goes all the way around inside our abdomen and terminates in this very specialized portion here shown in green, which is the rectum. And the rectum is like a waiting room when we have to go to the toilet, and it's very important in the mechanism of defecation. And we will see this evening what these particular properties of the rectum are, and why we try and replace them with the J pouch surgery. On the other hand, the small bowel or small intestine, which is in the bottom picture, has more of a central position inside the abdomen, and is the one we use in order to create the pouch. When we talk about pouch surgery, we often refer to J pouch because the J configuration is the most common way of doing the pouch operation, or IPAA, which stands for Ileal pouch anal anastomosis, or simply pouch, or sometimes we say neorectum of reservoir, stressing how important it is to replace some of the function that the rectum does. We said is one of the options, the J pouch, because after the colectomy, some patients will decide to have the ileostomy for a longer term or permanently, and sometimes this will require more surgery in order to remove the rectum, which is called the completion proctocolectomy, if this has not been done at the first operation. The focus of today's talk will be the ileoanal pouch, where we create a new rectum with the small bowel. And as you will see, it's a quite complex operation with different steps. And for this reason, we don't quite refer to it simply as a reversal of an ileostomy, because it's a bit more than that. And then the option here in the middle, which can apply to a very specific and selected group of patients, is where we can actually keep the rectum after we remove the large bowel and we do an ileorectal anastomosis. We won't be talking about this this evening. The rectum has a very special skill, which is called compliance, which means that when the rectum is there and is working well and is very healthy, if we have to go to the toilet and socially it's not convenient to do so, we can often wait a couple of hours until we go home, because the rectum can get bigger and bigger and accommodate more bowel content into it. And this is very important, because when it doesn't work, and patients with colitis know this pretty well, and the rectum becomes very inflamed and upset, unfortunately there is need to go to the toilet very frequently and to run to the toilet because of these symptoms of urgency and tenesmus. And the rectal compliance, this ability of the rectum to be a waiting room, is one of the main mechanisms that supports the continence, so the ability to keep and control the bowel motions on the inside. And continence also relies on the fact that we have very good and well-functioning muscles in the back passage, which are called the anal sphincters. But one thing to mention, and this is pretty relevant for patients with the J pouch, is that continence is also relying on the bowel content, the stool being of the right consistency. So obviously, if the bowel content is too liquid and too watery, the anal sphincters will be under more, will be doing more work and under more stress. So the first question for patient considering pouch surgery is about understanding that we are planning to replace with the small bowel a very specialized part of the large bowel, which is the rectum. And essentially, the rectum is this specialized part of the large bowel, and the large bowel is called this way because it's large, compared to the small bowel or small intestine, which is quite small, as you can see from here. So in order to try and recreate a new rectum and replace somehow what the large bowel is doing, we join together two ends of the small bowel, we stitch them together, and we will go through how we make that in order to try and create a new waiting room for the bowel content and try somehow to replace what the rectum was doing so well. And this is a video showing a pouch that we've just done in theater, and we're waiting to join it to the back passage. We are inflating and checking it with some water that we are washing through this catheter. And you can see how actually this trick of joining the bowel together works pretty well, because the pouch is distending quite nicely and can accommodate actually quite a lot of fluid on the inside. However, one of the other problems to mention around the operation to remove the colon and rectum has to do with the fact that the bowel content spends sometimes traveling throughout the colon, so that more water and fluid can be absorbed and the feces become of the normal consistency that we know of. And this is a textbook image that explains how much water and fluids travel through the gastrointestinal tract every day. And of these many liters of gastrointestinal content, normally in the feces, a very, very small proportion of it will be present, because the small bowel is reabsorbing most of it. But as you can see, also the colon has a quite pretty important role in making the food consistency more dry. So this is one of the problems. And then the other problem is that removing the rectum will mean that there is no waiting room, there is no rectum with this particular field called compliance. And we must make sure that patients have a very healthy back passage, because the anal sphincter will be doing more work, they will be under more stress. And for this reason, when we think about doing a pouch operation, we do some tests and investigations in order to make sure that the small intestine that we're planning to use for the pouch and the anus are healthy. And this is one of the reasons that before the pouch operation, doctors do have quite a lot of focus in excluding another form of chronic inflammatory bowel condition that is called Crohn's disease. Now, the main difference is that Crohn's disease, unfortunately, is a condition that despite surgery can come back again in the future, can recur, and also tends to have a preference for affecting the terminal ileum, which is this part here of the small bowel, and also the back passage, the anus. And for this reason, before the surgery, we will do a few investigations for checking that patients don't have Crohn's disease. And unfortunately, despite all these focus, there is still a good proportion of patients, in between 10 and 15%, who have chronic bowel inflammation that we call colitis, and we can't understand whether or not they have ulcerative colitis or Crohn's disease. These have been described as indeterminate colitis. And sometimes we never find out, sometimes only time can tell. But at the same time, we must be careful and not labeling patients too easily with the word in Crohn's disease. There is this tendency that all patients who have a J pouch and they start having problems with the way pouch works, they are immediately labeled, though actually they've developed Crohn's disease. It doesn't work exactly that way. Crohn's disease is a complex condition that requires many different steps in order to be diagnosed. And to give you an example, when centers would do a lot of operations to remove pouches in patients with pouch problems, they were looking at the presence of Crohn's disease in these pouches that had been removed. A very small proportion of patients, around 20–30% of all the ones that we were calling Crohn's disease of the pouch, actually had Crohn's disease. So there is, unfortunately, this habit of calling Crohn's disease everything that we find difficult to understand or to treat. And then the last question as an introduction to what the J-pouch surgery is, has to do with how many steps of the surgery are required in order to do a J-pouch. And to show you these different steps, I found it easier to do what I would normally do in clinic, which is draw some diagrams and explain what the steps of the pouch operations are. So just to also show you how low tech I am, I've used my son whiteboard to record a short video to discuss all the stages of pouch surgery.
Hi, my name is Valerio Celentano. I'm a colorectal surgeon at Chelsea Westminster Hospital in London. And in this video, I'm summarizing the different stages of the surgery to remove the large bowel and create an ileoanal pouch. This operation, called three-stage restorative proctocolectomy, means that 3 operations are generally needed. The entire rectum and the entire colon are removed, and the patient has decided for a restoration of the gastrointestinal tract continuity with the formation of a ileoanal pouch. The first step of the surgery is a subtotal colectomy with an ileostomy formation. And this operation will involve, if we go to the diagram on the left-hand side, if we see here, this is our esophagus and stomach that eventually will continue in the small bowel or small intestine that can carry on from 2 to 6 meters until it joins up with the large bowel on the right-hand side, where there is a little door called ileocecal valve. And then we have the colon here, or large bowel, that carries on inside the patient abdomen as a frame all the way around till we get to the last part of the large bowel, which is this very specialized area called the rectum that terminates with the exit door or anus anal canal, which is surrounded by some important muscles called the sphincters. Now, the subtotal colectomy involves removing this entire large bowel, which is sent to the laboratory so that the microscope can check the extent and severity of the inflammation caused by colitis, and making sure there are no other possible causes for the inflammation, like some infections or another chronic bowel condition called Crohn's disease that can affect the decision for future restoration of the bowel continuity. The surgery will preserve the rectum on the inside for several reasons. First of all, to avoid the longer and more complex operation of removing the rectum, which might be not a good idea on a patient who is very unwell with bowel inflammation, maybe on medications like steroids or malnourished. And secondly, to leave the option open for future restoration of the bowel continuity after the large bowel has been assessed at the microscope. So with this operation, the surgeons will completely remove the large bowel. As you can see here, the small bowel or small intestine now is completely disconnected from the large bowel and is used to create what is called an ileostomy, which is a stomach bag on the right hand side of the patient abdomen. Here, whilst the rectum, or as doctor often refer to rectal stump, is usually left 15 or so centimeters long and can be either left on the inside of the patient, or in case there are serious concern that this is extremely unhealthy and could perforate on the inside of the patient abdomen, can be connected to the skin, usually towards the lower abdomen, a bit more towards the left, as a mucus fistula. And this tends to be reserved only for a particular patient. The rectal stump is still affected by inflammation and colitis, but by being disconnected, usually patient symptoms settle very significantly and patient get much better, even if some occasional bleeding from the rectal stump can be expected after the surgery, and patient may require some topical treatment for that. Usually 3 to 6 months after this operation, the patients will go to the next stage of the surgery. However, some patients might prefer to remain in this particular situation for much longer because they don't want to have more surgery, or they want to have more time to think about it. The main precaution to be aware of is that in these particular occasions, it might be required for patients to have regular checkups every now and then of the rectum in order to minimize the risk of developing cancer. The second stage of the surgery is the proctocolectomy, which is the removal of the rectum and the formation of the ileoanal pouch. So the surgical team will remove the rectum, and surgeon need to make sure that the rectum is divided very, very close to the anus, around 1 centimeter or so, and this rectal cuff is not left too long, otherwise the patients in the future can develop symptoms very close to the ones of ulcerative colitis. And then the small bowel is disconnected from the ileostomy bag and is folded on itself as a J, and these two ends of bowel are joined together in order to try and create a bit of a bigger space and waiting area for the bowel content. This is the J pouch that is joined to the back passage using some special staplers, and this is called the Ileal pouch anal anastomosis. Very often the surgeons will prefer to protect the healing of this quite complex joining between the small bowel and the anal canal for a few months by diverting away from the pouch the small bowel content, and they will do so by creating a connection from the side of the small bowel, exactly the same location where there was an end ileostomy before, by creating a loop ileostomy. As you can see from this diagram, this loop ileostomy compared to the old end ileostomy will be a bit more active and more watery because there's been some more small bowel being bypassed by the stomach bag, so it's something to be aware of. And then again, after 3 to 6 months, the last step of the surgery can be completed after an X-ray of the pouch or an MRI scan or a camera test has been done in order to check that the full healing of this joint has been achieved. And then the last step is to remove the loop ileostomy in order to bring the small bowel completely in connection with the ileoanal pouch with the last step of the surgery, which is the stoma reversal. In some particular cases, the patients and the surgical team might decide to do together the first two steps of the surgery, and in that particular case, this will become a two-stage restorative proctocolectomy. And the final variation to this surgery is when the first step is performed, the second step is performed, but without the protection of the J pouch within loop ileostomy. And that particular sequence of procedure is called a modified two-stage restorative proctocolectomy. Thank you.
So these are this is just a recap of the different stages of the surgery I present. The three stages tends to be one of the most common, but obviously other stages can be all appropriate depending on the individual case. And how we can achieve good outcomes in pouch surgery. And good outcomes in pouch surgery, they rely very strongly on an expert team who is made by surgeons and other professionals who have expertise in this. And that's why, as you know, it is difficult to develop expertise in this operation, as this is a quite uncommon operation, and it's pretty obvious that if doctors are doing these operations or are looking after patients with a J pouch once a year, it will be very difficult for them to have and develop that particular expertise that is required in order to identify some of the problems that can happen during pouch surgery and after pouch surgery. Obviously, it depends a lot on the entire pathway. So the right decisions needs to be made, and appropriate and transparent communication there has to be prior to the surgery. And there has to be a pretty solid follow-up pathway for patients with a very proactive approach to pouch problems. And first of all, we must make sure that the pouch is the right option for the patient, that it is what the patient wants. And we need to focus on some of the factors that can be associated with pouch problems. For example, obesity, or the previously mentioned Crohn's disease, or a liver condition called primary sclerosing cholangitis, or PSC. It is essential to be surrounded by stomach care nurses and pouch nurses that can support and counsel the patient throughout the entire journey. And patients with pouches are actually part of our team. And as you know, with the work you do in this group, patients can support and counsel other patients, just sharing their experiences and advice on how living with the pouches. So these are some of the things that the doctors will do prior to do the pouch operation that we have discussed so far. And in this slide, I just wanted to add that a pretty important step before pouch surgery is for the previous biopsies, or in case the previous colectomy has been done, to be reviewed in order to look out for some of the features that we find are associated with Crohn's disease, and also checking that there is no history of previous perianal problems that sometimes can be a red flag, particularly if the pouch is not working well. But at the same time, we shouldn't be labeling every patient with either anal fistula or a fistula around the pouch as Crohn's disease, because this is not true. And I think we need to make sure we give the right treatment to patients. This is what a service looking after patients with the pouch should look like. And obviously, we must look after our patients at 360 degrees. There has to be a multidisciplinary team of dedicated surgeons, gastroenterologists, specialist nurses, dietitians, fertility specialists. The service needs to be focused on collecting the data that matters to patients, which are the patient-reported outcome measures, and needs to be and needs to be tailored to the patient's needs. So, for example, in our hospital, we offer pouch surgery to pediatric patients as well, and we have this specific service for adolescents that are in that very difficult moment that they are transitioning from the care of pediatricians and gastroenterologists and pediatric surgeons to the adult team. And we do that in different steps, and we carry on working together with the pediatric team throughout. Now let's move towards making the pouch. So we call it J pouch because the way of folding the pouch as a J is the most commonly used. Many years ago, the S pouch used to be a common way of making the pouch. However, some of the patients in the long term have developed problems with emptying the pouch, and many will require the insertion of catheters, which has mainly to do with this efferent limb here that you can see of a couple of centimeters and some adhesions and kinking that can happen in the S pouch around that efferent limb. So for this reason, the J pouch, which is easier to make for us and has better function, has become pretty much the gold standard, the only one which is used, even if the S pouch can be appropriate in revisional surgery or in patients where the pouch doesn't reach the pelvis. So the pouch has a very specific anatomy, the very specific wording that you can see here. However, the much easier way that I have to understand the pouch anatomy has to do with considering the pouch as having an exit door down here, which is the anastomosis in the anal canal, and having an entrance gate, which is the pouch inlet that will connect the pouch to the rest of the gastrointestinal tract. And then everything in between is called the pouch or the pouch body. And here is a diagram of how I present the assessment of pouch when I talk to healthcare professionals. As you can see, there are different areas of the pouch that we must assess formally every time we do, for example, a camera test of the pouch, or when we see patients in clinic, or when patients have MRI scans, in order to make sure that we really focus on all the different parts of the pouch where problems can happen, and where actually with surgery sometimes we can make things better. So what I'm going to show here is a few seconds a video of what the pouch look like when we do a camera test. This test is called the pouchoscopy, and the pouchoscopy will be able to identify all these different areas that are mentioned here. So as you can see, we're looking on the inside of the small bowel pretty much at this level when there are these two openings. One of them is the blind end, the other one is the pouch inlet that, as you can see, is a pretty wide channel that will take us to the rest of the bowel. And then as we start pulling the scope back towards the back passage, we can see the entire pouch body, we can see the anastomosis, and we can assess whether or not any residual rectum has been left there, which is the rectal cuff, which is normal practice to do, of about 1 centimeter, and we can see whether or not there is any inflammation or any problems. We can take biopsies, etc., etc. This is how we make the pouch in theater. This is where the on the left-hand side, where the old ileostomy was, we join together these two limbs of terminal ileum of approximately 15-20 centimeters each, and we use this special machine that is called the surgical stapler. That helps joining very safely and very precisely the two ends of the small bowel together, as you can see. And we do this for several times until we reach the appropriate length. And this is what the pouch looks like before we join to the back passage, as we saw earlier. Before we make the pouch, you might have heard people saying it's difficult for the pouch to reach. Now, if you see here, what we are demonstrating in this video with keyhole surgery, we are checking even before making the pouch whether or not the pouch will reach very down low in the pelvis where the rectum is and we're planning to remove. because sometimes there can be problems that, as you can see, it's a pretty long way that the small bowel has to go through in order to reach the back passage. And the final step of the pouch operation is joining this new made J pouch with the rectal cusp, and we often use this special circular stapler, as you can see here. And many years ago, the only way of doing this operation was by doing what is called the mucosectomy, where the surgeons will remove even the inner layer of the rectum and will join the back passage to the pouch with stitches. And this is still needed in some particular cases, but because it's quite difficult to join to make, and also because this mucosectomy can affect this anal transition zone, which is the last bit of the anorectal mucosa, which is pretty important to differentiate gas from solid when we go to the toilet and liquid. It's been seen that patients where actually we do the stapled anastomosis, they tend to have better outcomes. So that's the reason why the joining between the pouch and the anus done with the stapler has become the most common way of doing it. What are the pouch outcomes? So the pouch outcomes, if we look at the medical literature, the medical literature says that in between 7 and 10 patients every 100, lifelong will require surgery to have either a ileostomy bag remade permanently or to have the pouch removed. And this is called, with this very unfortunate and inappropriate wording, that is pouch failure. Many patients are happy with the J pouch. This is the average pouch function, even if obviously the average pouch function doesn't matter to the individual, and patients can go through period of times where the pouch function can change. There is a chronic condition called the pouchitis, which is very likely not only one condition, but is an umbrella wording for many different conditions that we call with the same name. And pouchitis, so when it's really pouchitis, the problem tends to respond quite well to antibiotics treatment. However, again, there is often the temptation that all patients who have pouch problems, they are told they have pouchitis. But pouchitis is a very specific condition where there are patient symptoms like increased bowel frequency, there are systemic symptoms of fatigue, and also there is evidence when we do the camera of the pouch that the pouch is inflamed, and also the samples, the biopsies we take are suggesting there is pouch inflammation. So it's not just saying the pouch is not working well, let's call it pouchitis, let's give it antibiotics. And the last thing to say here is that every decision making in pouch surgery has to be tailored and specific to the individual patient. What might be right for one patient and acceptable for one patient may not be right for another one. And it's important that you do ask the doctors looking after you and the surgeons proposing these procedures or telling you not to have this procedure, how often they come across patients with pouches, how many they do, how many they've done in the last 5 years. And if the answer is, once or twice in 5 years, or I don't see this patient commonly, or you don't have the answer, this is a red flag, because unfortunately this shouldn't happen, that this quite complex pathway is done in hospitals where there is no expertise for that. However, I think, again, and this has to do with transparency, I quite like showing patients what my outcomes are and what the outcomes of the hospitals where I work are. And I think, again, this is a way of helping patients understanding, what J pouch surgery is and what life would look like after a J pouch operation. So here on the left-hand side, we're looking at the last couple of years of patients that have had the new pouch made at Chelsea and Westminster Hospital, and we are focusing here on the average number of bowel motions in 24 hours. which is often one of the most discussed outcomes. But as you will see, there are others which are equally important, like, for example, the urogenital function, the social functioning, the fatigue, the fertility, the ongoing need for medical care, and medical admission. And as you can see, many patients have good outcomes. And it's important that people who want to do this surgery, they do collect these outcomes, and they're very transparent in sharing them with patients. And this is something we're really focused on. And we know all these patients really well. For example, these patients were marked here. She has an excellent pouch function, but she gets pouchitis very often. And when she gets pouchitis, the pouch function is completely different. Pouch surgery is a complex operation, and there are some problems that can happen in the short term. And the short-term complication of pouch surgery have mainly to do with the infections. And the infections after this delicate operation needs to be treated very proactively in order to make sure that the long-term results are not affected. Or there are long-term problems that are listed here, like narrowings or chronic infections again, or problems with the retained calf causing inflammation. Infections around the pouch can find many different ways. They can find the way posteriorly to the pouch, in between the pouch and the spine, and this is called a pouch sinus, or they can create connections, which is called fistulae with the vagina or with the perianal region. Narrowings are quite common. The most common narrowing is a ileoanal anastomosis down here, and this needs to be treated, very actively in order to prevent the pouch to be too dilated and distended and work under a lot of pressure. Or also the entrance door of the pouch inlet, that can also happen. Or sometimes at the site where the ileostomy was reversed years ago. And again, you can see that this patient that was told for 5 years that she had chronic pouchitis, actually she had the pouch inlet stricture, and we diagnosed her when she came to see us. And you can differentiate pretty easily how it should look like, the entrance door I was showing you earlier, and how it is on the top left picture. So we managed to do surgery, which is called a stricturoplasty, in order to make the entrance door bigger and wider, so there was no more stricture. Or again, in these other patients, we've had obstruction on many occasions, and we identified that there was a narrowing where the old ileostomy was, and we made it wider with stricturoplasty. So revisional pouch surgery is possible, and it is an option for patients where there is a mechanical issue, a structural problems with the pouch, like the ones we've discussed. But obviously, it's extremely important to understand what the patient goals are. And not infrequently, the patient will tell us straight away whether or not they are really reached a stage where they've had enough of the pouch operation, and for them, having the ileostomy of the pouch removed might be the right options. Or if actually they had a good time with the pouch and they would like to have surgery in order to make things better. However, these are the very recurrent problems of patients with pouches that has nothing to do with patients themselves. What I call the original sin is what we mentioned previously, and that's to do with surgeons doing the operation only because they think they can do it. If this surgery is not done regularly, if patients with pouches cannot access the full service and the very robust preoperative and postoperative pathway, surgery shouldn't happen there. And or all the same investigations are done, tests are done by people who don't do pouch surgery, or they don't see patients with pouches. So, for example, these are reports I received from patients who've been having problems, and eventually they are referred, and there is inappropriate wording, or there is no structured assessment of the pouch, or the abnormalities are not spotted, or as we said, they are labeled incorrectly, or people who are not into pouch surgery, they make decisions on behalf of the patient. And this is a real life example. I received from DGP the copy of this letter in between surgeons saying, I've explained to these patients that even if I don't do this surgery, I've decided that this pouch should be removed, which is really unacceptable. Or patients have problems of different natures, and we can only offer one solution, which is stoma permanently or pouch excision. It can't be like that for mechanical problems of the pouch. And finally, this is one of my favorites recently, which has to do with people saying, I don't do pouches, I just do the operation to remove the pouch. And if you think about this, this is, again, really unacceptable, as if you don't have the expertise in making the pouch, if you don't do all the steps of making pouch surgeries regularly, and you won't be able to offer surgery to fix problems for the pouch, and you will be incorrectly offering to people always removal of the pouch operation. And again, when we talk about revisional pouch surgery, we should talk about revisional pouch surgery and pouch excision at the same time. And this is to say that the solution to pouch problems, to problems of the structure of the pouch, can't always be pouch excision. For the right patient, there are things that we can do, like the ones that I've listed here. And in order to discuss this, I'm just showing the last very quick video, and then we'll go to the questions.
This video explains some of the most common operations that can be performed on patients who have a ileoanal pouch. You are all familiar with the J-pouch anatomy, which is here. The pouch has an entrance door, which is the pouch inlet, which connects the J-pouch with the rest of the small bowel, and there is an exit door, which is the connection in between the J-pouch and the rectal cuff, that is 1 centimeter of rectum that is connected to the anus, and this exit door is called anastomosis or pouch outlet. Many years ago, almost all patients who had the J-pouch had the mucosectomy, hands-on anastomosis, which meant that the J-pouch was essentially stitched directly to the anus and there was no rectal cuff. And nowadays this option is reserved for a very selected group of patients. Condition that is worth mentioning is when there is a narrowing of the pouch inlet, that is a pouch inlet stricture, and very frequently the pre-pouch ileum will be swollen and dilated because it's working very hard against the narrowing of the pouch inlet, and sometimes this can be treated with dilatation with use of an endoscope and the balloon dilatation, but sometimes surgery is required, and surgery can be a stricturoplasty where the area of narrowing is incised by the surgeons, which means stricturoplasty, meaning that the pouch inlet is sutured along the opposite axis in order to create a wider room for the pouch inlet here. There are circumstances where the stricturoplasty is not possible, and therefore the pouch inlet is disconnected here, and the new pouch inlet is created somewhere else onto the J-pouch, so that the patient has two different entrance doors. So here the old pouch inlet has been closed, and the patient has another pouch inlet that has been connected somewhere onto the rest of the J-pouch. So there is a new pouch inlet or pouch augmentation. Another potential problem that can affect the pouch inlet and the prepouchalium is when, due to the presence of excessive scarring or twists or kinking onto the pouch, there is a quite significant angulation of the pouch, of the prepouchalium going into the pouch inlet, leading to obstruction. And this often requires surgeons to remove all the scarring in between the pouch and the inside of the abdomen, and to fix with some sutures the pouch into its natural position, which is called a pouchopexy. When all these adhesions have been removed and the prepouchalium is brought back into its natural position with some stitches. A quite common location for strictures is also at the pouchenal anastomosis. Here strictures are extremely common, but can be often easily dilated by the surgeons in order to prevent the pouch from working too hard and getting bigger and bigger. When patients do suffer from a recurrent inflammation of the cuff and cuffitis, particularly if the rectal cuff has been left too long, surgery can be performed to shorten this rectal stump and performing a pouch advancement where the pouch is joined much lower and the extra rectum is removed. And finally, when the pouch is too compromised, either because of previous sepsis around the pouch or because of multiple narrowings, a redo pouch can be performed where the old pouch is disconnected from the rectum, the problems leading to the sepsis are addressed, and either the old pouch, when salvageable, or a new pouch is created and anastomosed to the anus to create a redo pouch. In these particular cases, often the patient will go through a period of time with a temporary loop ileostomy.
So the pathway to revisional surgery is patient-driven, and there are different investigations that you will need to do, like MRI scans or special X-ray with contrast into the pouch, which is the gastrographic enema, or assessing the pouch under anesthetics into a pouchoscopy. Not infrequently, prior to revisional surgery, a temporary stoma may be helpful in order to settle some of the infection and to improve some of the patient condition prior to major surgery again. And the option of a permanent ileostomy with pouch excision of revisional surgery needs to be tailored to the problem, but also to what the patient wants. Every option can be appropriate for that individual patient. And patients with pouches tend to have a very robust follow-up, which means patients can access the service directly. They can be supported by peer outpatients like yourselves. And there is a significant multidisciplinary input with dedicated dietitians and nurses, gastroenterologists and surgeons. And there is a lot of focus on collecting and addressing the quality of life and the function after pouch surgery. And from what we said throughout this talk, I strongly believe needs to be a very proactive approach where the pouch surgery team will look for problems and will act on them in order to prevent from having years of sufferance for patients with poor function or with bad symptoms that can be addressed. Thank you very much, and yeah, please feel free to ask any questions, and just an opportunity for me to thank all of my colleagues that support the pouch service, our gastroenterology lead, Dr. Wahid, my colorectal consultant colorectal colleague Sarah Mills, our specialist nurses Heather and Melanie, our lead radiologist Dr. Lee, and our pediatric surgeons Dr. Chowdhury and Mr. Chowdhury and Mr. McDonald. So thank you very much for having me and for all the work you do for pouch patients.
Well, thank you very much indeed, Valerio. That was absolutely outstanding. Can you hear me okay?
We can.
Yeah.
Yeah. Okay, that was absolutely outstanding. Thank you. I think the explanation with the diagrams that you were drawing at the same time when speaking, I think that's a really fabulous, simplistic, but very detailed explanation of the different steps of the operation. I really enjoyed that. That was terrific. Thank you. And I know there's been quite a few questions, and we'll try and get through them all. Just be aware, please, everybody, that if you're asking questions about your own personal situation, then Valerio won't necessarily know you or your situation. He won't have access to your medical notes. So please bear in mind with that, and please be patient. But I think there are some really, really great questions on the floor already. So I'll kick off and we'll try and get through. We've run a little bit on, but the questions often are the most valuable parts for a lot of the people attending. So let's try and get through them all if we can. So first of all, do the revisional surgery steps that you described, some of them, do they result in good outcomes? Do they work?
So they result in good outcomes if they're done for the right reason. So, you know, for example, the strictures, the narrowing in the pouch, they have a very, very good outcome because obviously, you know, patients have these frequent bowel blockages, so they have very good outcomes. So I think, or for example, when the rectum has been removed, when the rectum has been left too long, doing surgery to remove that long rectum and making the joint also has good outcomes. Overall, revisional pouch surgery outcomes are a bit worse compared to primary pouch surgery. So obviously, the ambition and the goal needs to be to, you know, make it right at the first operation. And that's why it's so important that the surgery happens, you know, in the right patient, done by the right people with the right follow-up. And but obviously, revisional surgery, if it's done for the right reason, has good outcomes. Yes.
Yeah, brilliant. Thank you very much indeed. You didn't mention the W pouch when you were comparing the S pouch with the J pouch. Is the W pouch now completely obsolete?
Yes, I think it's unheard of patients nowadays having the new pouch, which is the W pouch. Obviously, there are patients who have had the W pouch in the past, and you know, we look after them. And I must say, the ones I know have excellent function. So I think the concern around the W pouch is that perhaps it's a bit harder for us to do. There can be sometimes problems with the bowel emptying as the S pouch, and also the length of bowel which has been used in order to make it is quite a lot. But yeah, no, so nowadays it doesn't happen anymore.
Okay, that probably answers the next question, but it's a very good question, I think. If you have a certain configuration of pouch, so for example, a W pouch, and the pouch is not functioning well, can you have revisional surgery to revise it to a different shape, like, for example, a W to a J, for example?
You can, and however, obviously this will involve removing the old W pouch and making the new J pouch, and there will be a quite significant length of small bowel that will need to be sacrificed in order to do that. So I think unless there is a particular problem in that particular W pouch, we wouldn't advise people to go from one configuration to another, just to see whether or not it works better, because it's very much more likely to be worse than the one that you have already in place.
Yeah, so it's not a choice. It wouldn't be a procedure of choice for most people.
Correct, yeah.
Yeah, okay. And for issues like pouch emptying, would revisional surgery cure pouch emptying, or are there better approaches? I know that these are general questions, but they're very specific issues. But
well, I think first of all, there has to be some investigations to understand why there are problems with the emptying, because there can be different reasons why the pouch cannot empty really well, and often the treatment will be a conservative treatment, either with adjusting the diet, or for example, with what we call transanal irrigation, which actually we are using more and more frequently nowadays with patients with problems with the pouch emptying, and many patients find the benefit, or some patients will use the catheter. So if all these things don't work and don't make things significantly better, and if all the scans like the MRI scans or the gastrography have identified a specific problem, like, I don't know, for example, the pouch is very fibrotic, has a lot of scarring into it, and cannot be a waiting room as we wanted it to be, then surgery can be done to remake that. Or if there are lots of adhesions that are creating twist or kinking in the pouch, and that is the reason, then again surgery can address that. But I think that's why investigating pouch problems need to be done appropriately, because I think if you don't think of this sort of problems, or if you are not used to deal with these problems, you will never see them, you will never find them.
I think that's a really, really good point, actually. I mean, for a lot of these pouch-related issues, it's the investigation and the interpretation of the information that comes back that will guide an experienced team as to the best course of action. And I think, often we recommend to patients who are having persistent problems, particularly if they're not being treated in a high-frequency centre, that they may benefit from having a referral to a high-frequency centre with more specialist support functions available. Would you concur with that?
Yeah, absolutely. I think hopefully in a few years' time, I don't think there will be this option anymore. I don't think pouch problems will be allowed to be looked after in places where pouches happen very infrequently. And if we think about pouch surgery happening once or twice every 5 years in some hospitals in the UK, and some of these problems that we're mentioning happen in 5%, 2% of the pouch patients, it's easy to do the maths and see how rarely people can come across all these problems. So I think if there is a problem with the pouch which is not improving, or if always the same investigations are repeated without any changes to the plan of action, I think definitely asking for a second opinion, I think it's a very good thing to do, and I would be really surprised if a medical professional will do anything against it, we must encourage patients to go and see someone else for a second opinion. It's in our best interest as well.
Indeed, I think that's really well said, and the patient has a voice in this sort of circumstance, and I think that's really good to emphasize. I mean, just extending that a little bit, I had a comment on the questions for this one from Kelly about a physician not being perhaps fully aware of issues like pouchitis. What should we expect of physicians, secondary care physicians, and the GP population in terms of understanding, first of all, what an ileoanal pouch is, and secondly, issues relating to the pouch? I mean, is it GPs can't know everything, but is there, are they trained with regard to pouches? Do you know? Should we expect them to be fully informed, or should we be patient and, you know, be...
I must say, I'm a great supporter of how amazing GPs are, and I think they do a lot of hard work. They work under pressure, and they look after so many different problems. And I think expecting that general practitioners might advise and address problems of this very specific population of pouch patients, I don't know. I just find it very difficult to believe that, and that's why, you know, I've come back to the slide. You know, patients need to have a direct access to their pouch team. Full stop. You know, if you want to look after patients, you need to be obviously. You know, our email address for pouch patients is not an emergency point of contact. Obviously, we will still need, you know, IME and GP practices for that. But, you know, within a reasonable time frame, we can go back to our patients. And now, obviously, pouch centers very often we look after patients who live quite far from the hospital itself. It has to do with the nature of doing an operation, which is quite rare. So, you know, what will happen for us, for example, we know that that particular patient has had episodes of pouchitis in the past and has responded with that particular antibiotic. So when the patient gets in contact, we will say, you know, we will get in touch with your GP and we will facilitate that prescription because it's local for you. And I must say this works really well.
Yeah.
And so I think yes, obviously, you know, GPs can prescribe antibiotics. Yes, they can prescribe suppositories. But, you know, many general surgeons and colorectal surgeons don't know much about pouches. So why we should expect general practitioners who are not gastroenterologists, who are not surgeons to know about pouches? But that's what I think.
I agree. I think it's natural for patients to feel frustrated if they don't feel that the particularly the GP is not fully aware. But I think it's very difficult for them to be fully informed of every medical condition that they may come across. But just a little plug for the Redline Group medical alert card. I don't know if you can focus on that. On the back of the medical alert card is a QR code, and the QR code leads to a landing strip which is specifically written for GPs and medical practitioners. You can take your card into your GP, ask them to download it, add it to your notes, add the information to your notes, and it does give them a lot of information about pouches. So that's one little tip. We're going to talk about a couple of topics that have come up, Valerio. One is strictures and one is fistulae. So first of all, about strictures. Conscious of the time, but why do strictures develop and how easily are they resolved?
Well, difficult to say why they develop. I think the presence of the stricture has to do with the presence of scarring or fibrosis. And I think, you know, repeated inflammation can lead to scarring. Sometimes in the pouch inlet, particularly when there are other adhesions outside the abdomen and there is a bit of a kink or a twist in the pouch inlet, there could be inflammation. The anal canal, as we said, is an area of very high pressure because obviously the sphincters are increasing the pressure in order to keep the bowel movements on the inside. So the pouch itself has this tendency, particularly down here, to develop strictures. And I must say, I'm not saying they happen almost in every patient, but I think they are pretty common. I think it's just the degree of severity that can change. And that's why sometimes the pouchoscopy needs to be done with the very tiny little camera, which is the gastroscope, the one that we normally use for checking the stomach, or eventually needs to be done under anesthetic so that some stretching can be done of this most frequent stricture, which is the one at the ileoanal anastomosis. So the one at the ileoanal anastomosis, if there is a proactive approach to it, so your team will check for that every now and then, or where there is a change in the way your pouch works, they can be addressed pretty easily. The problem is if they are left for many years, then eventually the pouch will get very swollen, very upset, very dilated, and then we will have that problems of difficulty in completely emptying the pouch, because obviously it becomes like a very big watermelon where there is a lot of stuff that can go on the inside, but then not everything will come out.
Yeah.
Pouch inlet strictures, they can be treated either with the, very often with the endoscopic dilatation, pretty successfully. Sometimes when they're a bit too long, surgery is needed.
Yeah. Okay, and if we've had ulcerative colitis, and that's the reason for the original proctocolectomy, are we more likely to develop scar tissue because of the inflammatory response? Our bodies have already shown a propensity to overreact immunologically. Is scar tissue more likely or not?
I wouldn't say that. I would say something a bit more generic, which is if we compare pouch problems in people who had the pouch for FAP, which is the genetic condition of polyposis,
Yeah.
or for colitis, usually pouch problems tend to be a bit more common in the colitis population compared to FAP. So there has to be something that has to do with it. And but I don't think it's specific for the scarring. For example, FAP patients tend to have other forms of scarring or problems inside the abdomen that are called desmoid that sometimes can cause this problem. So I wouldn't say that UC will make narrowings and strictures more common.
Okay, great, really good, thank you. Let's talk about fistulas. We had a couple of questions on fistulas, and fistulas are really, when they occur, they're problematic. One of the questions is the presence of fistula or fistulas a reason for pouch failure?
So, I mean, it's a very important question. The first thing to say is that yes, in many patients who end up having the pouch removed, which is one way of defining pouch failure, the fistula tends to be a important contributing factor to it.
Yeah.
So that's true to say. However, the problem with fistula is that it depends quite a lot on when compared to the pouch operation happens.
Okay.
And for example, if you have a pouch operation and few weeks and months after the pouch operation you develop a fistula, this is very likely nothing to do with inflammation or with Crohn's disease. This has to do with an infection happening at the time of the pouch operation. This infection was unfortunately not proactively treated and has found its way on the outside of the patient with the fistula, which is what our body tries to do in order to protect us from becoming unwell with infections, tries to push them on the outside. And fistula can be treated and can be treated sometimes medically by making the inflammation of the pouch better when we can identify reasons for that. Often they require surgery. Very often the surgery is to settle the infection with something called seton, which is a special stitch inside the tunnel of the fistula. And eventually they can, settle with the infection and they can be repaired. So there are things that can be done with surgery in order to repair the fistula. However, again, there has to be a very open conversation with the person who has the fistula, because healing the fistula or treating the fistula can be very frustrating for the patient and for the surgeon, because it can require many operations. Things can get worse or not better enough after an operation. So some patients, I not infrequently come across patients with a fistula. They say, I just want to have a checkup and make sure everything is okay. But then when we go into more steps to address the fistula, they're actually more than happy to be left alone. And so again, this has to be, tailored. Obviously, if there is a fistula with the narrowings of the pouch and there is a lot of increased output of the pouch that the patient needs to wake up many times, overnight, then we mustn't wait that patient to live 10 years for that before saying, actually, probably we should remove the pouch or do a stoma bag. Because
10
I think
years. 10 years. Wow.
well, patients can wait many years before the right decision are made.
Yeah.
And I think, if they have very bad function, if they have very bad fistula and they're having horrible quality of life, there is no point in postponing these decisions. I think, they need to be offered the appropriate treatment that could be either having the ileostomy or having the pouch removed. And because obviously it's a matter of getting the quality of life better. But obviously the focus needs to be in trying not to get infections or to treat infection at the time of the surgery itself.
Yeah. Yeah.
Pouch fistula are a not infrequent problem and they can be difficult to address.
Yeah. And I think there's a very good webinar recording by Philip Tozer and Lillian Reza from St. Mark's Hospital in the library on the Red Lion Group website, and they were researching specifically on causes and treatments and outcomes of fistula care. And their conclusion, Philip Tozer's one-word statement about fistulae were, they're tricky. So I would suggest to anyone who's listening who is interested in understanding more about fistulas to have a look at those webinars, because that is a really good, I think, webinar on the challenges. If we look at, I think you presented a really great slide on frequency as an outcome, bowel motion frequency with amongst patients that you'd seen at Chelsea and Westminster. That's the one, brilliant. And I just wanted to make a couple of points on this. The first is, I think this is a terrific, we get a lot of people applying to become members of the Facebook group or indeed the charity who are potential pouchees, who are interested in learning more about the procedure and the outcomes. A lot of the questions relate to frequency post-operation. And I think this is really good because it demonstrates, I think, that it's a range, that even for individual patients, within patients, there's a range of frequencies depending on whether they're having a good day or a bad day. And I think highlighting the fact that if people have pouchitis, then they can have two different frequencies depending on whether their pouchitis is active or not. But one point I wanted to make is that when potential pouchees are looking at things like outcomes, they should be comparing the outcome with the same outcome if they have a stoma, because their outcome of going back to having a full large intestine and as they were before any surgery is not an option anymore. So in terms of quality life assessments, it's not relevant to think about how does that compare with their old life. I think when people are counseled with regard to a pouch, they should be comparing ileostomies with pouches. And if you did that with this sort of graph, what would be the frequency for a stoma patient? It's slightly different, isn't it? Because the stoma is constantly active.
Yeah, it is different, and I must say the ileostomy obviously is works in a very different way compared to the pouch. Very often patients are patients with a difficult pouch with problems. They know very well how difficult sometimes it is to be in charge and to be in full control, whilst actually within ileostomy, you tend to have more control over the, when to empty it and the output. But, I agree that within ileostomy, patients will require to empty it and to care for it several times a day. But what matters to me in these slides, I think, is demonstrating that we need to know our patients really well, because this is a complex and delicate operation, and we need to measure what we do. And I think it's also to give patients the option, because I think some things that will happen very frequently is that doctors and surgeons that don't do pouch surgery, they will refer to pouch surgery as hell or horrible or a very bad idea. And this is the same with the revisional pouch surgery. And you know, that's not true. I don't think our role is to persuade or dissuade patients towards having a pouch for an ileostomy.
Yeah.
I think it's about telling what we know, how we care for patients, getting the shared expertise of other patients, and then the patient can have, you know, make their own decision. But you know, there's so many pouch patients who have a very, very active lifestyle, and they manage to achieve in life what they want with the J pouch. And I think this frustration for patients and surgeons is being unable to predict the ones that will do badly, because obviously nobody wants to do an operation and then the outcome is not good. I mean, it's very sad for us as well. So, but unfortunately, we are not there yet. But I must say that I am aware that the pouch operation in the past are received, you know, quite bad publicity. But I don't see that. You know, I think you know, all these nightmares. I don't see them. I think they have to do sometimes with pouch problems that have not been addressed.
Yeah.
The patient is unlucky, and that pouch problem happens. There are solutions to it, and you know, sometimes the solution is an ileostomy or a pouch excision. And but again, you know, the team needs to be proactive towards offering those solutions.
Brilliant. I think you've just about, in that quick fire session, addressed all the questions. I notice it's almost 5 to 9, so we've gone a little bit beyond what we thought we would do. May I thank you on behalf of all the audience this evening, and of all your patients as well, if I can be so expansive, for a fabulous talk and really detailed, considered consideration of the questions that were asked. And thank you for giving your time this evening. And from us all, carry on all the great work that you're doing. Really wonderful work, and we wish you the best of luck in the future. For everybody present, please do log on and register for further webinars in the series. We'll be posting more information over the coming weeks and months with a program, quite a detailed program of pouch-related webinars. And don't forget, there's a fabulous pouch forum, a relaxed pouch forum, first Monday of every month, when we get together and just have a really informal and really pleasant chat amongst pouch patients and potential pouch patients via Zoom, so from the comfort of your own home. But that's it from me, and thanks again to Valerio, and thank you all for joining, and have a great week, and stay warm.
Thank you, Valerio.
Bye-bye.
Okay. Recording will be available very soon, probably by tomorrow.
Thanks, Gary.
Okay.
Thanks again.
Thanks all. Thank you. Bye-bye.
Bye-bye.
Bye-bye.